Welcome to Ask the Psychologist, a live program intended to discuss issues of a psychological nature. I'm Dr. Heidi Neville, and my co-host is Judy Holt.
And as always, our show is for educational purposes and not intended to be a substitute for therapy. We are so happy to have with us tonight Donna Lang from Washington Hospice. Mm-hmm. And Donna, there's so much we want to ask you, but maybe we'll just start with having you tell us a little bit about what is hospice and who is it intended for?
Hospice is actually aggressive treatment for symptoms and not for a disease, to keep people comfortable, symptoms that are managed, and improve their quality of life. Anybody that does not want aggressive treatment or is not offered it can accept hospice. They need a prognosis of 6 months or less, not saying that at 6 months, that's a certain time. Things go on longer, things go on shorter. None of us can predict that. But it's just for anyone that doesn't want the treatment or there's nothing out there.
Now, how is hospice initiated? If somebody is been hospitalized and they find that they do have a terminal illness, how then do they connect with hospice?
Well, hospice is actually an election. So they, either the person, the family, the people that are in charge of their care simply can ask, I want hospice. Can I get more information about it? Sometimes the doctor can see, and as they approach the patient and say, you know, you've been receiving treatment, we don't have any treatment for you, I recommend that you seek information about hospice. If you're in a hospital setting, it kind of works the same way as if you're at home. A hospice representative, they write the consult for you. Hospice representative comes in, talks to you about everything that would be basically apply to you, whether you want to have hospice in your home, whether you're at a very acute stage that you need it in an inpatient center, or if you don't have caregivers and you need to live in a facility, they'll talk to you about all those things. To have a consult on it, you don't necessarily need a doctor. But for someone to come out and admit you, you need a doctor referral. So it's really asking the question. Anybody can ask for hospice. Any discipline, any type of physician. Sometimes referrals come from your oncologist. If it's end-stage heart disease, it'll come from your cardiologist. It can come from your nurse asking, you know, you want hospice. So it really can come from anywhere. When they're outside of a hospital and in their home, they can do the same thing. Call up, say, I want someone to talk to me. Simply a representative comes out, sits with the family, talks about everything that possibly could fit their needs. So basically it's open to anyone.
You know, I know one thing that would be very important to establish is how is this paid for?
It's really, if you're talking a Medicare patient, hospice is a benefit of Medicare. No matter what you have, it converts back over. So any of your Medicare HMOs, it does revert back. Any of the insurance plans, private ones, have now, most of them, have picked up a hospice benefit. Some have ceilings on them, so many thousands of dollars. Some, you have to get authorizations. So if they're inpatient, maybe every 7 days you have to call the insurance company and you have to say, you know, give them an update and say, okay, if they're in home, every 30 days you call the insurance company and you get an update. So it really depends, but over anybody with Medicare, it's easier. It's just a given and it converts over. Private insurances are a little different, but the same thing. The same things are involved. You still get nursing and nursing assistants and social workers and counselors and equipment and medicine. Everything with hospice, it's a package. You have to have all the disciplines and all the people in order to offer hospice. And so that's because everybody gets everything they need instead of acute care.
Well, what does hospice actually do? If you're coming into a home and you have a patient that has a terminal illness, which of course they would, what do you do?
Well, actually, for everything that has to do with end of life, We provide care to increase and to make the quality of life better. We don't make death happen sooner. We don't extend it. We make whatever time you have quality, whether that quality is giving you dignity just to be able to stay in your own home with your family, whether that quality includes pain management, symptom management, nausea, any of those things. It's just to make the end of life easier, and not just for you as a patient and as the person that's stricken, but your family members. So it offers all the counseling needed, support systems to help you from that day to the end, at whatever level you're in, to adjust to that disease from an acceptance, because sometimes people haven't even reached that point. They've just been told, you have cancer, I can't do anything, or you have, your kidneys are failing and we can't do anything with you. So to go from diagnosis and actually through death. Wow. And treat all the psychological issues, the physical issues, bereavement for when you pass. For 13 months after someone dies, you will have contact with a bereavement counselor. Based on what you need.
The family will have contact.
Family,
with yeah.
And at whatever level, whether it's one-on-one, where it's support system, group, holiday, where things are a little bit harder. They have holiday sessions for 6 weeks before the holiday, so it's really whatever level that you need.
So it sounds like you go in and you have a multidisciplinary team, kind of, and you assess what are the needs here, and you try to, as you meet them where they are, and
get them to move along with it and accept it. Everybody accepts it at a different level, a different understanding. So if this is a middle-aged adult, sometimes the mom's still living, it's going to be a lot different dealing with that mom because it's her child. Then you have a husband there. So everybody has so many needs. But we go in and it's always, oh, hospice comes in and they take over. We don't. When you get a referral, when it's 6 months or less, you have a lot more time and you take things at a slower pace, and maybe you don't need any equipment at the time. Hospital bed, oxygen, you just need someone to start out, a nurse, just to assess you once so we can keep up to the doctor. But when it seems like hospice takes over is when you get the referral and they have a week probably left, and you come in and they not only have pain, but they need oxygen, they need a bed, they need mom sitting there, grandma sitting there.
Services.
Then it seems like we do, because we try to at least help right there, and we have a short period of time in which to do it. So.
Yeah, I know when people talk about hospice care, a major component is pain management. What is within your jurisdiction in terms of what can you provide? Do you need to get a doctor's recommendation for a prescription? Do you have the authority? How do you assess?
Everything that hospice does is through a doctor. We utilize the doctor that the patient wants or family. Sometimes it's the PCP, the primary doctor. Sometimes it's the oncologist, because once they've been diagnosed, they haven't seen their primary doctor for a year. So whatever doctor it is, we go through there. So say that they have pain. Some primary doctors aren't comfortable with higher doses, but we'll call them up and pain's not controlled, you know, they're rating of a 4 out of a 10 and they're only on this much. Can we do this? And we always offer. If for some reason the doctor's a little bit leery, I haven't given that much, I'm not comfortable with that, we always have our medical director. We meet with him weekly. We discuss our home care cases, we discuss our inpatient cases, and we'll say, we have this patient and primary doctor's thinking this way, what do you think we need to do on this way? Then we can call the primary doctor and say, you know, our medical director recommended this. Sometimes we have to hook up a doctor and they need to talk. But the nurses of hospice do not prescribe. That's not our role. We do make recommendations based on what we see, because we're a liaison between the physician and the patient. The patient really doesn't need to go to the doctors anymore. To waste that time and energy getting in and out of a car, in and out of the doctor's office. If they wanted to, they could go to the mall. that kind of thing. Utilize the time they have left for things they want to do, not for things they have to do.
Right.
So that's what we try to do. So as far as medications, we use compounding pharmacy. So not everything we offer has to be taken by mouth. It can be creams and suppositories and lotions and a lot of different routes. Our medical director, he's certified in palliative care. Similar to a cardiologist in the heart, he's certified in that. So he uses a lot of different things that a primary physician wouldn't even know about, as far as creams and topical morphines and inhaled narcotic. So it's a lot of different ways, and I think that's why hospice can do it so well, is because they see that side of it. They've learned that. And primary physicians, it's like a primary physician trying to do foot care. I'm sure he can get him and cut the nails, but can he really do that? I don't know.
Donna, are there any other, one misconception you mentioned was that hospice comes in and takes over, and maybe that would be a barrier to people asking for it. Are there any others you can think of, misconceptions that might keep people from using your services that you would like to educate them about?
There are a lot of misconceptions. I started in hospice over 15 years ago. So the hospice that was there and the hospice now it's two different things. Even when I left it for a while and came back, I thought, oh, is that true? Is that true? People think that you have to be a do not resuscitate to have hospice. CPR, call 911, ventilator. They didn't think that that was possible. Now it is. Some people are just diagnosed. They're not ready to say, I don't want CPR. So people can elect hospice, remain that full code, that CPR, and as the disease progresses, we work with the family, with the patient to accept and see, well, maybe that's not a good idea. Another misconception is you don't get treatment. You give up when you get hospice. You just change your focus. You change it from palliative care to quality care instead of treatment, aggressive treatment for the disease. You treat the symptoms. We don't test, we don't do all that. Oh, you got a cough and a cold and it looks like you have an infection. We're not going to send you for the chest x-ray. We're not going to do all that. We'll give you an antibiotic. Why should someone have to sit there and choke and cough?
Right.
Same with any kind of infection. We'll give antibiotics, from the doctor and to treat those. So we do treat, and it's not giving up. It's just accepting, making the end of your life, giving it quality, doing things you want to do because your time is limited. So that's another misconception.
From a psychological perspective, I'm sure that you work with both the patient as well as the family and the emotional aspects of end-of-life issues. In your experience, what have been the more difficult areas or problems that you've had to confront from the patient's perspective and or the family?
A lot of times people have expressed that there's some things they didn't say that they wanted to say, some people that they haven't talked to for a while, some bridges they needed to mend. They don't want to leave family members behind, that they know they're going to a better place and they don't want to leave here. Those kinds of issues. It's a sad time of their life, but it's a very good time because a lot of people know, and when they get enough warning and they get on hospice early enough, they can do those things. They can mend those bridges. They can talk to people that they wanted to talk to.
So closure is a big, helping them and the family achieve that kind of closure so they don't have that guilt and regrets.
And it's easier for them to let go. People often think that if their family members in bed and they're not talking, that they don't hear them. And we always say, they can hear you. Just talk. It's just their way of pulling back so that they don't have the interaction, but they can still hear you and still talk to you. And you have to let them go. You have to tell them it's all right. A lot of people need to, to hear that. And a lot of people think if they're going to stay by the bedside, they're going to be there when they die. It's the one that leaves the door and they didn't want to die when they were there. As soon as they walk out of the door, and they wanted to. They didn't want you to see that last breath. And sometimes that really bothers family members because they thought, oh, I missed it. I was there the whole time and I helped them. But it's okay. It's really okay. Nobody picks. You don't have a choice as a family member. I don't have a choice as a caregiver, you know.
I think it's extraordinary, the work you do, and I think it must take a really special person, Donna, to be able to do that. Your staff, they must have some certain characteristics in common to do this.
They're wonderful.
I was gathering
they're
that.
wonderful. They, you know, it's stressing, the job they do, and but they can walk in with a family in trouble or a patient, and they just do it. They do it well. You know, nurses are nurses, and they're always told that they're social workers to a certain extent, and we have a great social worker and a great counselor, but nurses are CNAs. They're all counselors. They're all hearing. People that are intimate with someone hear a lot more than someone that directly asks the question. And do you ever give someone a bath and they sit there and tell you everything? So our staff is well versed. They're good listeners. I think that's the biggest thing. It's not always what they say, it's how long they can listen and
They
what
must
they
be
do.
very
Sure.
comfortable to be with and make people feel comfortable very quickly.
Very compassionate.
That's important.
Yeah, they do a wonderful job, and I think it's people know they want to do this.
Or else they wouldn't.
No, you just can't walk in and say, I'm going to be a hospice nurse, and you
Yeah.
know, it's just not one of those fields that you do that to.
One of the areas we were talking about before the show started was the frame of mind of some of the physicians, that a lot of physicians come from the perspective of we keep treating and trying to heal and cure. Do they feel that they're giving up when they make a referral to hospice? And how difficult is it for the physicians to let go?
It's very difficult, especially someone that's trying to fix everything. They've always fixed them. They've known this patient for 30 years. They have fixed their heart. They have actually gone through their children, gone through everything, and all of a sudden they're at the end of their life. I have to fix this too. No, they don't have to fix this. They just have to help them through. A lot of physicians, especially older physicians, are not used to the concept of hospice. They think it's for the last few hours of life, the last couple of days. I've often called a doctor for hospice, well, they're not dying yet. Well, not yet, but it doesn't mean that's not when you elect hospice. You know, it's better early on. So it's a lot of teaching to physicians or telling families, you call your physician up, you tell them what you want. Because a lot physicians feel too that some people are pushed into things a little bit earlier and maybe they're hesitant of it. But in teaching families, teaching everybody around you that, you know, what is hospice? It is for end of life, but the longer time you have, the more prepared you are. Younger doctors now, through their residency programs, do follow-throughs with hospice, with palliative care. So they're seeing it early on. I get so many referrals from family practice, from residents, because they're educated and they know. And it's not saying anything negative about an older physician, it's just something new.
Right.
It's, you know, it's changed just since I've been in it. Imagine how long some of these physicians have been along. It's changed a lot, an awful lot. They're still back there maybe with, you don't treat anything, you don't do anything. And so
Hasn't hospice, the concept, been around a long time?
it's been around forever,
Yes,
but
it really has.
you'd be amazed who you approach with it. Oh, what's that? What's that? So it's,
How long has it actually been a concept or a formal concept? Do you have any idea?
I know it's been, and it may have started in England.
I think you're right. I think you're right.
I think it have, and it's been around for a very, very long time. Like I would say, decades.
Wow.
And it's just evolving, because before, palliative care and hospice were the same. Now, nationally, within the last 10 years, palliative care and hospice have separated.
Can you define palliative care?
Palliative care now is when you are seeking treatment, but you have symptoms. What has happened is acute care is over here, hospice is over here. There's a certain group of people in the middle that are falling through. They have symptoms, they can't get the specialty from hospice to treat that, and they're in the acute care, and somebody's still fixing kind of like the disease and not thinking about the other parts. So palliative care is the treatment that people receive when they're accepting treatment. So if someone's getting chemotherapy, radiation, they have heart disease and they're getting IV therapy 3 times a week, or they're still on dialysis and their symptoms aren't managed, or someone that's had surgery and they're in pain, they qualify for palliative care. So what you're going to have is symptom managed, and you provide that continuum from acute through palliative care. When the end of their disease comes, it crosses over and they continue through hospice. Palliative care is billed just like an acute, where hospice is grouped. It's a lump payment for every service you provide. So palliative care has been in the facilities, has been in the home. It's new to Washington. They've done a palliative care consult service for about three years. They have now a palliative care unit. It's only a 3-bed unit, but it's on the oncology floor. So this unit for palliative care, say someone got chemotherapy and they're dehydrated and they're doing a lot of vomiting, what would be the perfect thing is, instead of coming in the ER, getting all worked up, this person has cancer. Well, we knew that. You don't need to do an MRI. You don't need to do a PET scan. You don't need to do all that blood work. They just need hydrated, go home. So they can go up to the palliative care unit. There's an order set, so you don't have all of those tests that they don't need. They hydrate them, they go home. Their quality of life is preserved. You longer stay in the hospital, the more you pick up things. So they're in and out.
That's true.
People that are in facilities, end-stage Parkinson's, they often aspirate and get pneumonia. We don't need to bring them into the ER, work them up. We know what's wrong. Bring them into the palliative care unit, get them on their IV antibiotic for their aspiration pneumonia, get them back to their home, which happens to be a facility.
You know, my dad had end-stage Parkinson's, and he was in a nursing home. So I know exactly what you're saying, because anything that happened, he had to go through and have all the tests and all the workup, and it was...
It's heart-wrenching to say, we're doing this again. And then they come out and there's bruises up their arm because they have no fat left on their body, and you know, they're bleeding underneath. We're just working with facilities. We have a nurse practitioner now that will actually go into the facilities for palliative care to educate the staff on, this is where we are, can we do this? Because no matter what you say, that facility's their home. When they're there without hospice, say, then for everything that happens, they have to go back to the hospital. They have to get retested. When you have hospice, they can stay in the facility. Oh, it's okay, hospice is here. We don't have to do that. We can just get an antibiotic. Oh, they spiked a temp for 2 days. That's okay. You know, we'll give them
Do you
time.
have different regulations?
Yes, when hospice is involved, the regulations for a skilled facility are very strict, and I just met with them a couple weeks ago, and they've gotten a lot worse. So for them to do high doses of any narcotic, for them to do their anti-anxiety pill to keep them calm, very strict, a lot of documentation. And to have a PRN in a facility, it doesn't work well.
I don't know what happens. I know you mentioned about 6 months is often what's prescribed if somebody lasts. But often you hear about people that last longer. And who was it recently that was in the newspaper who was the political satirist that just had gone into hospice? I don't know if you remember, Jeff. His name escapes me. And he was writing his last articles from hospice care. But does that happen often, that people will live longer than is anticipated? And then do you continue your services beyond the 6-month time period?
Every 90 days, a patient is re-looked at. The doctor has to sign orders. For cancer patients, it's easier. And then everything that's gone on with that patient goes to the doctor. He looks at it. He'll re-sign him for another 90 days and another 90 days, and then it goes to 60. Someone that's not cancer, there are actual worksheets for heart failure, Parkinson's, general debility, age alone. 102 years old, you deserve to end a life.
Sign me up.
But there are worksheets that say if they haven't been in the hospital for a while, then you can't use the category for the test of the heart and those different things. But it's all signs and symptoms. Can they complete a sentence? Well, in the next 90 days, maybe they can only say 3 words. Before, they were totally walking around. Now they're bedbound. So there's criteria to meet. So then they're recertified and recertified. Actually, people improve. You get symptoms managed. It's amazing how well people do. We've had people be discharged from hospice. They've done so well. They've gone to a facility and gotten physical therapy.
So people can come in and out of your service also?
It's an election. You can elect hospice. If you have cancer and you elect hospice and a new chemotherapy comes out, you can say, I don't want it right now. I'm going to go try that treatment. You can go try the treatment. If it fails, you can come back and say, I want back on hospice. It didn't work. You can do that. If someone gets stronger and they think, I think I don't want that anymore. I think I want more aggressive treatment. You can do that.
It sounds like you're very flexible in your approach and try to really assess what people need and meet those needs.
It's really all about what the patient and the family wants. We're here to provide a service. Hospice is about making choices that you want. We have the things out there, what you want. So yeah, flexibility is a big part of it because you're talking about the end of someone's life and choices and making no regrets, having no regrets. So you have to have them.
It sounds like a major component is education.
And I think that's mostly what you do, whether it's from a medicine down to making the choices that you have, and even end of life, making an advance directive. I want this, I don't want that. It's a lot of education. And healthcare is. I mean, that's a specialty you only learn about when you need it.
Right.
So it is a lot about education.
Not only to your clients or your patients, but to the general public.
And the more people that learn about it, the more people that someone comes up and says, my mother this, and you know, even if you know a little piece of it, well, I heard this. It gets people talking, and that's how we get a lot of phone calls. I was told, and then you further educate them on what it is and if it fits.
Now, how large a program is your program? How many staff do you have? How large a community do you service?
Hospice Care of the Washington Hospital is not a large company, I guess you want to say. We do service Greene County, Washington County, and Allegheny County that's on the verge of Washington County. We have just 4 home care nurses, 2 CNAs, nursing assistants. But it's nice because they see the same people all the time. You're always going to get somebody that you know. Hospice offers an on-call 24/7. So if you saw a nurse today and you end up having trouble, the chances are that nurse that you saw in the daytime knows of you. She's on call. So if you get in trouble, she knows you, or you've seen them. We try to vary it so at least when you're on call, you know that nurse.
And they'll travel throughout the whole area to see their patient.
And we have the Donnell House, which is an inpatient center. Use that kind of like an emergency room for our hospice. You're in trouble in the middle of the night, and you can come in instead of going to the hospital.
Wow. That sounds like a wonderful program, Donna. And we're so appreciative that you've come on the show to share this information to the folks in the community.
Well, thank you for having me.
Thank you so much.
Now, if
for
somebody
coming.
wants to reach you, what's the number where they can get a hold of your program or you?
724-250-4500, or you can just call Washington Hospital and they'll find us.
And if anybody has any questions, I can refer to Donna. My number is 724-941-7075. And thank you, Donna, for coming on the show.
Thank you.
And it's good to see you, Judy, again.
Oh, good to see you. Stay warm.
Yes. Thank you.
Thank you.